A very good afternoon to everybody. A warm greeting from our institute. I'll be giving an overview of allergic eye diseases, followed by other views related to it by different instructors in the course. We all know that allergic eye diseases affect 30 to 50% of population, and out of that, 50% have ocular symptoms. Now, why this topic has been chosen? It's because of this. We are puzzled, we are confused, we are baffled, we are unsure, we are lost, we are unclear. And why this baffleness? This baffleness is basically in diagnosis as well as in treatment. Why in diagnosis? It's basically due to similarity in symptoms and signs. Traditionally, we have four kinds of allergic eye diseases, that is simple allergic, perennial allergic, vernal, that's what we call BKC, and AKC, that is atopic keratoconjunctivitis. The hallmark features of each one of them is ocular itching, whether it is seasonal or perennial. Now, how to differentiate them? Because there lies the baffleness. So how to differentiate them? And that's what we are trying to clear here in this forum. One, on the basis of severity of itching. Second, the onset and duration of symptoms. Third, the clinical signs. Now, if you look into the simple allergic conjunctivitis, it is always associated with mild itching. And it is seasonal in nature because the triggering agent in this is pollen, which is usually a pollen. And how does it act? It triggers the mast cell, and mast cell leads to two phenomena. One, the degranulation, which leads to the production of various mediators, and the most common of them is histamine. And the second is the phospholipase pathway, which leads to the production of prostaglandins and leukotrienes. Now this histamine, prostaglandin and leukotrienes, what it does? It basically causes vasodilatation. These are the mediators which are responsible for ocular itching. And that's why we see a classic feature in simple allergic conjunctivitis, and that is the hyperemia and ocular itching. This hyperemia is obviously because of the dilatation, that's a vasodilatation. In addition to that, we get mild papillary hyperplasia. But what about PAC, that is perennial allergic conjunctivitis? Please remember that the features are similar to that of seasonal, but the difference lies in the perenniality, means it persists throughout the years. It is not secondary to the pollen, but it is secondary to the persisting agent like animal dander or the dust mites. And these are mild triggering agents, and that's why you have mild clinical features in perennial allergic conjunctivitis. So basically the difference that we have between the simple allergic conjunctivitis and perennial allergic conjunctivitis is in duration of symptoms and signs. So how to differentiate PAC with VKC? Both are perennial in nature. So how to do that? First, the onset. VKC is invariably seen in children, and it usually lasts till late teens. Regarding the geographic distribution, VKC is more common in tropical zone like in our country. And the symptoms, the ocular itching, the hallmark symptom, it's a most severe, it's a severe in nature in VKC unlike in PAC. Now if you look into the signs, you can appreciate that in PAC you have mild papillary hyperplasia, whereas in VKC you have large cobblestone papillae. They are invariably seen the large. And it is because of the fibrocytic reaction that is seen in this VKC. In addition to that, we get the gelatinous mass of the limbus along with Horner's tenta spots. Corneal affection is very common in VKC, unlike in PAC. And this corneal affection is basically due to release of various toxic proteins, especially from the eosinophils, and also secondary to the various mediators which are released following degranulation of the mast cells. So what happened initially, you have the SPKs. Once they confluent, they lead to the production of or the formation of this shield ulcer. Now, when the limbitis persists, what it does, it basically destroys the limbal stem cells, and that's what leads to the features suggestive of limbal stem cell deficiency. This is one of the patients at our center. You can very well appreciate there are large cobblestone papillae in VKC, and it is the grade 2 shield ulcer. Grade 1 is where you just get the erosions. Grade 2 you can get these fibrin deposit as you see here. And grade 3 I'll show you subsequently in a patient with AKC which has a plaque in it. So it is following treatment, it has occurred like this. Like we gave the transnone, supratarsen as well as the AMG. Now question arises, is there any pathognomonic feature of VKC? Yes, it is perilimbal pigmentation. And there are numerous literature, there are numerous articles in the literature which suggest so. This is another literature from I. So whenever you are confused whether it is VKC or not, just look at the perilimbal pigmentation, and if it is there, it is pathognomonic of it. Now what about AKC? AKC is also perineal in nature, like VKC. So how to differentiate them? The symptoms are also quite severe in this, especially in terms of itching. But the onset if you see AKC, it is seen in adults. There is always a history of atopy in form of atopic dermatitis or bronchial asthma. And unlike VKC, which affects primarily the upper tarsal conjunctiva, AKC, the lower tarsus, is predominantly involved. And the subepithelial fibrosis is also more common in AKC unlike in VKC, and that's what leads to pharyngeal shortening and symblepharon formation. Now this is a patient who came to our center, a 53 years old male, histopathologically proven atopic dermatitis. He is having the atopic dermatitis since childhood. He is also having atopy in form of bronchial asthma. He was bilaterally blind. He was brought to our OPD with his colleague, and this was the feature in the right eye. You can very well appreciate here that there is an epithelial migration which is seen here. This is suggestive of limbal stem cell deficiency. You can see a plaque here, grade 3, which is again suggestive of a shield ulcer, which is also there in AKC, but it's a grade 3 type as per Cambrian classification. This was his left eye. You can very well appreciate that there is again epithelial migration. There is inflammation, suggestive of cellularity and vascularization. You can very well see a large shield ulcer with plaque in it. So we managed it with topical steroid. Dermatologist was there who administered azathioprine and prednisolone, and this is the picture after treatment. This is in the left eye. So at least when he was not able to walk himself, now he is able to walk himself with just the medical management without any further intervention. And he's quite happy with that. Though some of the cases are quite well managed, but there is still a challenge in terms of treatment. And why this bufferedness is there in treatment? Because there is no set pattern of treatment strategy, and also there are multiple anti-allergics available in the market, so we are all confused. I think the subsequent speakers will highlight how to get rid of this bufferedness. Thank you for your patient here.
Thank you, Dr. Alok, for an excellent presentation. Do we have any questions, anything anybody would like to ask Dr. Alok?
I would like ma'am to answer this, because role of blood test for the allergies normally we do not do in our practice, because we do not know which is the agent, which is, it's very, very broad thing which is very difficult to do it. And I don't know what is the significance of it really.
The only test of relevance could be for detecting hypereosinophilic disease. So if the eosinophils are very high, then you know that you are dealing with a very severe form of allergy. That is also not so common in Indian population. Even if
one thing is, blood test is a very general term you said, so of course we all sometimes do serum IgE, but there are specific tests which can be done to determine whether the patient is allergic to any specific factor. So you have these type of tests where you challenge the lymphocytes with the allergen, the patient's cells, and then you can figure out whether to confirm the allergy you can use certain tests. More often what is done is the pinprick or the skin tests, which are where you can sort of use maybe 100 allergens or 50 common allergens in that geographical area and then do the testing. So the blood tests are there, but for each allergen there is a separate test, and there will be very few maybe you could do just for confirmation, but routinely, as I think the panelists have mentioned, we don't do these tests. But what is commonly done if you want to try immunotherapy is the skin prick testing to know the allergens,